Perhaps you've heard people talk about the Omaha system, but it's all Greek to you. Then you're in the right place. I'm Karen Munson, and I've used the Omaha system for over 25 years. In this presentation, I'll explain how the terms and definitions of the Omaha system work together to create a comprehensive, holistic view of health. Like any fine instrument, there is a lot of detail under the simple yet elegant surface of the Omaha system. This training will reveal exciting secrets you can use to your advantage, both clinically and from a program evaluation perspective. The secret is in the structure. The Omaha system is made up of 42 building blocks called problems that describe all of health. When you understand the structure of the terms and definitions for a single problem, you understand the structure of the whole entire Omaha system. You can document everything pertaining to each problem in the same way, and I'll go over everything here in more detail on the following slides. Priority, modifiers, signs and symptoms, interventions, and outcomes. Let's start with priority. The Omaha system allows you to document whether a problem is high or low priority for your client and their care. That's simple Simon. If it's important and you're addressing it, choose high priority. But if it's a side note and you just want to document something about it for the sake of remembering down the road, choose low. The priority decision can be a useful tool for educating students or new staff in understanding that not all client issues may need to be addressed. Priority is typically a non-essential data element, unless deemed necessary for a particular program, population, or project. Next, let's talk about the identity modifier, individual, family, or community. The Omaha system allows you to document whether a problem pertains or belongs to an individual, family, or community. Most problems pertain to individuals, even though most individual problems also affect family members. Therefore, I suggest you default to individual and realize there will likely be an impact on the family. This makes sense from a billing perspective, as we typically bill for services to individuals. A problem may also pertain to a community. This may be deemed necessary for documentation regarding a particular program, population, or project. The identity modifier is typically a non-essential data element, as you'll be able to trace the identity data to individuals and programs using demographic variables. Next, let's talk about the severity modifier. The Omaha system allows you to document the severity of a problem. Again, simple Simon. If there are signs and symptoms, it is an actual problem. And if there are no signs and symptoms, it is a potential problem. Very rarely we may have a health promotion problem, such as when normal elementary age students learn about healthy diets. This would typically be a non-essential data element unless deemed necessary for a particular program, population, or project. Next, signs and symptoms allow you to document details about each problem. Each problem has a unique set of signs and symptoms. You can easily select the signs and symptoms that you observe when you assess the problem. Signs and symptoms are very useful. In addition to providing specific details about the challenges clients are facing, we see that more signs and symptoms tend to indicate more client needs, which is a red flag clinically to help in care planning. Next, let's talk about interventions. The Omaha system allows you to plan and document care. Interventions always address a problem using the problem, category, target, guide structure. Each part of the intervention structure provides important information. The problems classify all of health. The categories describe our actions: teaching, guidance, and counseling, treatments and procedure, case management, and surveillance. The target terms are defined terms that help further specify the intervention together with the problem and category terms. And the guides are not defined and may be customized to give us the exact details necessary for a particular program, practice, or population. Problems structure our pathways, with each problem having one or more problem, category, target, guide, intervention to show us a menu of likely services. This structure helps to keep our thoughts organized and aligned with evidence-based practice, and also greatly helps save time documenting. Occasionally, you may need a different intervention from the usual. When this happens, it's easy to create one because Nightingale Notes gives you choices from the problem, category, target, guide structure. Finally, the Omaha System allows you to track 3 types of outcomes: knowledge, behavior, and status. And these outcomes are also very useful. KBS ratings always rate a problem using a simple 1 to 5 rating structure. Knowledge is what the client knows, behavior is what the client does, and status is how severe the problem's signs and symptoms are. If there is a sign or symptom, status cannot be 5. Don't overthink it, and if you're not sure, check in with a friend. How you use the Omaha System is up to you. I'll describe streamlined and detailed documentation approaches. Streamlined documentation should include signs and symptoms, interventions, and KBS. These data are typically more than enough for program evaluation and staff feedback. Consistent streamlined documentation reinforces high-quality practice as well as providing good data. Detailed documentation with selected priorities and modifiers, in addition to the streamlined data elements, may be important for education setting or particular programs, populations, or projects. These details may be less important from a big picture or data perspective. Let's see how this works for the pain problem. Pain is a problem that is found in the physiological domain. We'll take it as an example and apply the Omaha System as described in the previous slides. First, priority. Pain is usually a high priority. Next, let's consider the identity modifier, individual, family, or community. Most problems pertain to individuals, and pain fits with this rule of thumb. Next, the severity modifier for pain, actual, potential, or health promotion. Recall, if there are signs and symptoms, it is an actual problem, and if there are no signs and symptoms, it is a potential problem. Therefore, pain is an actual problem if pain is present, and a potential problem if it is not. Next, let's look at the signs and symptoms of pain. The pain problem has 6 signs and symptoms, including expresses discomfort, pain, elevated pulse respirations, blood pressure, compensated movements, guarding, restless behavior, facial grimaces, pallor, perspiration. These help to discern and document when a person is having pain. Here are 2 of many possible interventions that may be used to address the pain problem. They are written in the problem, category, target, and guide structure. The first is for administering non-opioid pain medications, and the second is about teaching guided imagery techniques. What about pain, knowledge, behavior, and status? Let's say this person is post-op and knows what to expect but is not an expert on pain management. They're taking care of the pain as best they can, but because they're having pain, it's not easy and they may be at risk for inappropriate self-medication. And they have severe pain, perhaps 7 out of 10. So that would be a 4 for knowledge, a 4 for behavior, and a 2 for status. Let's try this again for the mental health problem in the psychosocial domain. Mental health is usually a high priority. Most problems pertain to individuals, and mental health fits with this rule of thumb. Mental health is an actual problem if mental health signs and symptoms are present, and a potential problem if they are not. The Omaha System has a comprehensive list of mental health signs and symptoms for the mental health problem. I will not list them all here, but some of them are difficulty managing stress, difficulty managing anger, and mood swings. And here are 2 interventions that may be used to address the mental health problem. The first is for surveillance of mental emotional signs and symptoms with a PHQ-2, and the second is for helping to schedule a counseling appointment. What about mental health, knowledge, behavior, and status rating? Let's say this person understands that mental health providers may be available through their work, but not how to use services. Let's say this person has difficulty managing stress and consequently sometimes misses work. And let's say this person has moderate signs and symptoms because they do feel good most days, even though they struggle with stress. That would be a 3 for knowledge, a 3 for behavior, and a 3 for status. You've seen how easy and intuitive the Omaha system is to use. Just imagine you have at your fingertips all Omaha System problems working the same way within Nightingale Notes. The Omaha System was developed especially for an automated charting environment, which makes learning the Omaha System easy and intuitive within Nightingale Notes. You already know everything you need to know to use them.